Hello, everyone. My name is Russ Rels. This is the Kelvin Jones, lead clinician at the Prosthetic and Orthotic Institute. We are located in Rock Hill, South Carolina, Pineville, North Carolina, and we have a location in Lancaster, South Carolina. Today, Kelvin is going to teach us about spinal bracing. We go on these Community Connect calls to discuss different aspects of prosthetics and orthotics to help educate our patients, as well as our referral sources regarding the technologies that we provide and the services that we provide. So we have talked about the different types of suspension systems for prosthetics. We have talked about different types of feet for prosthetics and when you would use those types of feet, and then we correlated that with the K levels. So kind of bringing it all together with that. So we're gonna change topics today and go into orthotics, and specifically Kelvin is going to educate us on spinal bracing. So thanks for taking the time, Kelvin, and looking forward to this discussion.
Sure thing. Thanks for hosting. So today we're going to cover really the cervical spine all the way down into the lumbar spine and how we as orthotists manage fractures, scoliosis, spinal conditions such as kyphosis, other abnormalities you may have in the spinal column. We also manage injuries with compression fractures and different types of conditions we treat. So we're going to talk about those today. And again, really quick, we're going to have a better understanding of orthosis and how they are available to our patients and to patients that we treat. And then obviously the relationship between us as an orthotist, your neurosurgeon, your spinal orthopedic surgeon, your pediatric orthopedic spine surgeon, your neurologist. There's a number of different physicians and specialties that we treat, referrals from them for different pathologies. Physical medicine rehab doctors refer a lot of patients to us. So that's the objectives of today's presentation. So next slide.
All righty.
So as we look at the spinal column in the human anatomy, we have 7 cervical vertebral bodies. And in those 7 cervical vertebral bodies, those are obviously, they're all very important, but that kind of serves in the anatomical spine from right below or right at the area of our chin, and then going right behind into our occipital, right behind our skull, and integrated into the skull all the way down into our upper cervical spine, which is right above and terminates about the scapula area and your clavicle area of your anatomy. So if you touch your, what we sometimes will call clavicle or shoulder blade, some folks will call it, that's where the cervical spine terminates. So again, we have 7 of those, right? And so then we have this thoracic vertebral bodies, and we have 12 of those. And those are where the rib cage are housed inside the anatomy of the spine and are protecting the internal organs. And then the next 5 vertebral bodies we have are what are called lumbar spine, lumbar vertebral bodies. And in there is where a lot of our rotational movement happens in the spine. A lot of our flexion moments happen in the spine. When we have car accidents, that's where a lot of fractures happen in the thoracic and lumbar region. And then finally, you have the sacral vertebral bodies. And in that's really our tailbone along with the coccyx. So folks who have a fall sometimes and land on their bottom, they will sometimes fracture their coccyx and their sacrum area. Very painful. It's really difficult to brace this area. Matter of fact, it's impossible to brace your coccyx area. But our scope of practice is we are referred those patients through a neurosurgeon, again, neurosurgeon, orthopedic spine surgery, general orthopedist who's dealing with spinal injuries of patients. We see a lot of folks through the emergency room, through the ER with car accidents, and again, physical medicine rehab. So that kind of gives you an anatomical view, right? If you look on the left side of your screen, that's really what's called a coronal view from the front part of the anatomy, and then on your right side is a sagittal view or a side view. So that would be, if you're looking at directly looking at someone in the face, like you're looking at me on camera today and Russ, the one on the left is what you'd be looking at, and on the right would be looking at someone from the side, right? So we all have what's called a kyphotic curve in our thoracic vertebral bodies, and then a lordotic curve, which is where it scoops back out, for lack of better terms, on the lower vertebral columns.
All
So
for a reason, I'm sure, right? There's a reason.
All for a reason. So when athletes injure their spine, Tiger Woods, he's a great example, right? Has had multiple back surgeries, multiple issues. All of his issues were down in the lumbar and thoracic spine. I don't know whether or not he required bracing or not. And then you take someone like Peyton Manning. Again, this is dealing with the neurosurgical aspect of it, so out of my scope of practice. But neurosurgery would certainly consult these patients when there's neurological involvement, where there's numbness in the legs, there's numbness and tingling in the upper extremity as a result of a cervical injury. And so they would then handle what type of surgical option there may be in place. Also, how to treat that conservatively with bracing. So we sometimes will come in to see those patients as well. And then if you look on the far right of the picture, you see what in the posterior compartment there, or on the back side of the spine, are what we call pedicle screws, or I'm sorry, not pedicle screws, but pedicle vertebral bodies. Those pedicle bodies are what house the spinal cord. So the spinal cord actually runs back behind the vertebral bodies that are in the front. So that's a good anatomical view of the anatomy here that we're going to talk about today.
Wow. Okay. So, if I look down in the lumbar, it says L1, L2, L3, L4, and then it says ankle dorsiflexors, long toe extensor. Are you saying that, or is this indicating that the L4 has something to do with my ankle?
That's correct. So in the spinal column, again, that houses the spinal cord, these are where the innervations take place. So in other words, if I have a spinal cord injury that involves the actual spinal cord with what we call retropulsion or an incomplete spinal cord injury, those are the muscles and the activators that are affected by having that injury. So if I have an injury, say at the L1 region, well, everything distal or below that you see described here is what's going to be affected by a result of that spinal cord injury. So I sum it up to our patients in as simple terms as possible, is it's kind of like the drop cord that's feeding electricity to the hairdryer, right? Or the drill. The drill is the muscle. The drop cord that's feeding that is the spinal cord. Our brain is the wall socket. And so we may know what we want to happen in our brain because the accident may not have affected our brain, but it affected the spinal cord at that junction, say the L1 junction. And so the spinal cord or the drop cord is getting a shorted signal in that area. And as a result, everything distal to that, such as the muscles that are described here, are what are not working properly as a result of that injury. Wow. So it can get very, very complex. And that's why neurosurgeons and orthopedic spine surgeons and physical medicine rehab, that's why in their scope of practice, they make those really, really complex decisions about how much spinal cord involvement is really there, what are the risk factors for having surgery, what are the outcomes, what are the research, and so that's why we always hear brain surgeon, neurosurgeon, spinal cord, physical medicine rehab physician, orthopedic spine physician. All those folks deal with this specifically day in and day out. So that's really their territory, their scope of practice, and what they deal with these complex injuries.
Wow. Pretty smart fellers and women, men and women for sure. All right.
So next slide here. So why brace? A lot of folks come to us every day in our clinic. We may see folks in different hospital settings, whether it's an emergency room, outpatient. We may see folks inpatient stays, but these are a number of conditions we treat, right? So we want to mechanically control the spine. So we're trying to control what we talked about earlier, the rotation, the flexion, and the distraction of the vertebral column, right? So those three planes, and we can do that with the spinal column being controlled by a brace: flexion, extension, and rotation.
What is flexion? Flexion.
So a flexion injury, let's just take that for example. We have folks all the time who are driving down the road. They simply have a fender bender, or they're rear-ended really hard, and they may flex forward really fast in the car as a result of the seatbelt. They're not going to be ejected. It's going to save their life, but something's got to give, right? So we have a spinal injury or a compression fracture. So that would be a flexion injury to the vertebral column. And we're going to look at those injuries here in just a second on our next slides.
Oh, okay. Okay.
And then we cover also fractures, dislocations, post-operative management of the spine of someone who's had a spinal fusion. And the surgeon may recommend them being into a spinal brace, either because he may know or she may know that they're very non-compliant beforehand, and as a result, they want to ensure that their work that they put in with instrumentation is going to steady them and keep that patient compliant and really prevent them from doing curricular activities that they shouldn't be doing. Osteoporosis, osteoarthritis, and then degenerative disc disease are major contributors to a Bowery brace. So again, we talked about the cervical spine. This is just a more in-depth view. You can look at this later and going forward. I'm sure this will be up. But so some cervical pathologies or fractures that we treat as orthotists. The neurosurgeon gets a call, and there's a patient in the emergency room, right, with a fracture, and they may have a burst fracture, an anterior wedge fracture. You may see a dislocation even, and you typically, when you see a dislocation of the vertebral body, that's a major spinal cord injury, depending on how much retropulsion is there. And the neurosurgeon always makes this call. That's their responsibility and really their scope of practice. And we sometimes work as well with the physician assistant. He may make the call, or the physician assistant may read the x-rays or the MRI reports to let us know how we need to treat that patient. These are just different types of fractures that we may see. I like to sum these up to our patients as treat the spinal column as bricks that are stacked on top of each other. And in the middle of those bricks are wet cement. And that cement never really hardens up. And what it becomes is a shock absorber for those bricks, right? So as the bricks are taking compound throughout the day as we're walking, sitting, standing, think about an abrupt stop, such as someone who falls off a ladder but lands on their feet, or even lands on their bottom, where that wet cement is actually squished out, right? It's pushed out, and that vertebral body catches that as a result, and that's where the brunt of the force is, and that's how we end up with compression fractures and burst fractures. So that talks about this in the cervical pathologies. Next slide, we'll talk about it in the thoracic as we get there in a couple more slides. But these slides here, I want to show you orthotic treatment that we do for those fractures. So top left would be what's called an Aspen or Vista collar, and the bottom right in the navy blue is what's called a Miami J collar. And so these are minimally invasive orthoses that we use to treat small categoric fractures in the cervical spine, anywhere from 0 to 15 to 20% of compression. These are cervical collars that you always see paramedics, ambulance put on folks out in the field during a car accident, right? Because they don't know, they didn't see the accident. And what's just as important as anything is stabilizing that spine, especially cervical spine of that patient, because they may not know or may not be coherent enough to tell us if they hurt their spine or hurt their neck, have a neck injury as a result of a car accident, but the chances of that are pretty high. So they will put these collars on a lot of folks. And if you're out there today looking and you've had anything from cervical laminectomies or a cervical fusion, any minor cervical surgeries, complex fusions, you're probably familiar with these two braces. So these are just examples. I want you to see this as truly that, as examples of braces that we use for cervical spine treatment. Next slide, Russ, is halos. So I'm sure someone in our audience today, if you're looking at this and you're dialing in as a result of hearing spinal issues and spinal fractures, and you've heard or seen someone or had a family member who's worn a halo, it is terrifying, just to put it quite frank. It is not fun to see this superstructure on someone. It certainly isn't pleasant looking. but it's very effective. And so when we think about this, I always tell our patients we have boundaries, right? And the boundaries are is how much limited range of motion do we want a patient to have. And so if your neurosurgeon makes a recommendation that we're going to place this patient in a halo to maximally stabilize their cervical spine, that's why we'd use a halo. And so a cervical fracture would require this sometimes. We also have terms such as Hangman's fractures, and cervical dislocations are what require halos for intervention. And so it's maximum control of the spine. That's when these are needed. And so again, your neurosurgeons would make this call, neurosurgical PAs would make this call, cervical spine specialists would make this call to really gain maximum control of the cervical spine.
And are they with these? Do screws actually go into a person's skull? How does that work?
Yeah. So for our audience today, if you weren't familiar with this, this is a little education. So we actually use screws to tap into the skull at specific landmarks on your skull. And when we put these on, we actually have we use a Newton meters wrench that actually allows us to get it to a certain specific tightness. It's dialed in, and once it reaches that Newton meter spectrum, the wrench will then click and allows us to know that that's as tight as we need to go. So really, we are drilling into the skull when we place a patient into a halo. And it's kind of cool afterwards. If you're a patient who's worn one of these and you're out in our audience today, as you know, when someone said we're going to put a halo on and we're actually going to put screws in your skull and we're actually going to keep you stable and we're actually going to be about 4 to 5 centimeters from your brain, that's not a fun thing to hear, I'm sure. But the outcomes are typically pretty good with these. And we're seeing less and less use of halos in this country as a result of neurosurgeons. Again, research and development, they can typically perform surgeries now that will help stabilize that spine a lot faster. And so again, that's really their scope of practice, but we're seeing less and less halo usage today in the country as a result of R&D.
Cool.
So cervical thoracic orthotic treatment. How does this work? So this is just a cervical orthosis on steroids is what I like to call it. And so we as orthotists, we have this gray area that's really hard to brace. And that's really between C7 and really T8, T9. So if you are sitting out in our audience today, if you kind of find your xiphoid process, which is right above your belly button, is where your ribs start to connect and you've got your sternal column going up. T9 is about right behind your finger. And so you can kind of see where T9 is hanging out here on this picture Russ has. And so from T9 proximal up into your C7 area, that's a really difficult area for us as orthotists to brace. So anytime I get a call with a patient who's got a T7 or a T8 wedge fracture, or even a C7 wedge fracture, that becomes an area that's really difficult to brace because we have the ribs, we have the scapula, we have the clavicle, and we have all these bony structures around that area. So it's really hard to stabilize it, but inherently you're stable, but just the way our bodies are formed. So we use the Minerva and the CTO, cervical thoracic orthosis, on those patients quite a bit. And those are pictures and examples of those. And so those are highly adjustable. We use those quite frequently on folks who are in the ER and we need immediate relief, or someone who you may just have a minor cervical fracture or upper thoracic fracture, and your neurosurgeon or ER physician has written for a CTO. We'll minimally, just minimal involvement. In other words, no retropulsion. It's just really a bony break. We can put patients in these and they can be discharged that day from the hospital. So these are just indications for the halo, like we just talked about, for the CTO.
So what is an indication?
So indications for that, again, bony fractures. Typically,
I know okay. So what I meant was, like, what's the definition of indications?
Oh, indications are, well, you have indications and contraindications, right? So if I've got a patient who's got an unstable fracture, A contraindication would be a Minerva or a CTO brace. They would be more likely to go into a halo because the halo offers the maximum support and control. So a contraindication would be the Minerva would be an unstable fracture. An indication for a Minerva would be a stable fracture. So we have simply just a bony break.
Okay.
And the bone just needs to heal back to its proper height.
So an indication is less severe injury than a contraindication.
Not necessarily.
Oh.
So you're going out to get a pair of running shoes, right? And this is a good analogy. You're going out to get a pair of running shoes, and you say, "I really like that pair of shoes." And the gentleman at the shoe store says, "Well, are you a pronator?" And you say, "No." Well, what is a pronator? It's when you have really flat feet. And he says, "Well, these shoes offer pronation control." So that's a contraindication for these shoes. If you don't have flat feet, that's a contraindication for a pronating shoe. So you don't need that pronation support. So much like contraindications and indications mean that's the filter we use to see what's going to be more helpful for this patient.
Oh,
would they be more stable in a halo, or would they be more stable with a Minerva brace?
Okay.
So hopefully that helps to bring a little clarity to it. So we're going to move to the thoracic spine.
Okay.
So as we're looking at the thoracic spine, we have 12 of these vertebral bodies, and these all house, again, your rib cage. This is where everything is. Your internal organs are all housed here. And it's, the human body is just phenomenal how God designed the human body, right? So we got these fingers that are ribs, and then we got the sternal column that's protected here on the front to protect our heart, lungs, and internal organs. And so in the back, we've got 12 specific vertebral bodies that house those ribs. And so we don't have a lot of rotational movement in the thoracic spine. We do have flexion, we do have extension in the thoracic spine, but as a result of that, it's very protected because of the superstructure around it with the ribs and the sternal column. So next slide here, Russ. Some of those fractures, or some of the fractures that we see here. As you can see in our pictures here, the red highlighted areas will show you some of the more common fractures we see with pedicle fractures, vertebral body fractures, and compression fractures. So the majority of the time, whenever we're called to the hospital to evaluate and treat patients who may have a thoracic or lumbar fracture, it's due to a compression fracture if it's because of a car accident. Believe it or not, one of the most common injuries that folks have is ATV accidents. So you're on your four-wheeler or your dirt bike and you're jumping hills, right? Or you decide to pop a wheelie, and when you do that, or you're landing abruptly on your spinal column, all that force is traveling through the spinal column. And as it is, we talked about those bricks on wet cement, something's got to give. And that's typically what gives. And when it does, you end up with a bony fracture. And so we measure those compression fractures in percentages from 0 to 25, 26 to 50, 51 to 75, and then 76 to 100%. And so we have those four columns, those four percentages that will determine how we brace that. So those are the indications we look for to help us decide what type of brace to use. If I have a 40% compression fracture on the vertebral column, but there's no retropulsion, the neurosurgeon says there's no neurological involvement, this gentleman or this young man is perfectly fine, except for a bony spine injury. We will put them into a custom TLSO brace, or sometimes we can fit them with an off-the-shelf TLSO brace. All depends on their anatomical build. But the most severe, or one of the more severe fractures that you can see here is in the second slide over to your left. That's a complete dislocation of the vertebral body, and that's a very unpleasant outcome.
Oh,
typically that means that the spinal cord has at least some minor involvement and sometimes major. And again, that's where neurosurgery steps in and says, look, we got some decisions to make, and that's where they make those calls of how to treat that condition.
So you mentioned TLSO bracing. What does that acronym stand for?
So let's let's go to that. Well, I think we're going to get there in our next couple of slides here. Let me
Okay.
finish up lumbar. So you see a thoracic spine here, and this is thoracic bracing. So Russ, what I've shown here, and for our audience out there, these are very off-the-shelf, low-involved thoracic bracing that we use. So we have this term that we like to use called the thoracolumbar fracture. And so as I told you, you have 12 thoracic lumbar vertebral bodies, 11, 12, and then L1 and 2. So that is a very common area to have fractures. Why? It's because 11 and 12 are at the end of the rib cage, and 1 and 2 of the lumbar spine are where your rotation starts to happen. Okay, so that's where you're starting to get really involved with rotation in the lumbar spine, and you're leaving that rib cage safe area of the thoracic spine. So a lot of injuries happen there because that's where we begin to flex, extend, and have the ability to rotate. So common fractures happen in that area. We treat those with Jewett brace, cast brace, hyperextension orthosis. So most of the time when you have a seatbelt fracture, that's a very common term, believe it or not. We see a number of folks in the ER that have been involved in car accidents that have a seatbelt fracture. And so that's a result of you flexing forward really fast, as we talked about earlier. You compress that spinal column, and as you do, it kind of catapults forward and then relaxes. And when it does, you lose the height of that vertebral body, and the brick is now crushed. So it's hard for the common person, but if you've worn one of these orthoses, you actually get and understand what you're seeing here. We're providing 3 points of pressure. So I'm going to provide pressure here in my upper thoracic spine, my lower thoracic lumbar spine, and then I'm going to create an extension moment in the posterior part of the spine. And I've got a couple of different braces here. So this is just an off-the-shelf TLSO brace, but you can kind of see this is where the abdomen is. This is your chest area. And on the chest area, this will provide 2 points of pressure running posterior. And then in the posterior compartment, we're going to actually be pushing and forcing into the anterior compartment to provide relief where the fracture site is. So in other words, we're opening up that space to allow that vertebral body to grow back to the normal height and to heal that area. All right?
Yeah.
So next slide. So we just talked about the hyperextension orthosis and how those work. Kyphosis is let's talk about a couple of conditions that we see sometimes. So we all have that family relative who's typically older. It's sometimes female, who's up in her 70s or 80s. They may have a lot of kyphosis due to osteoporosis. And what that is, we treat a lot of patients here in the clinic whose grandmother or mother, they use a walker for so long for ambulation that they start to kind of get the hunchback. And as a result, you can imagine you're resting on your spinal bodies throughout the day. That gets pretty painful. So we see a number of folks in here for kyphosis treatment of degenerative joint disease and osteoporosis. But these are just a few of the conditions we treat with hyperextension orthosis. Sherman's kyphosis is a kind of a cousin of scoliosis. And so it's a congenital thing that happens in the spinal column where you literally have an arch in your back where your spinal column is kind of at a bridged moment where we've got to relieve that as you're growing. And could be painful. Typically, it's a condition that happens over time. So we treat that with different types of TLSOs. All right, next slide. So now let's talk about that TLSO. So here is maximum control, right? With the TLSO brace, we can control you in all 3 planes. It's used a lot for postoperative stabilization. Unstable fractures from the L5 to T5 region we talked about, mild kyphosis. But as you get a still picture there of it, I also want to show you a picture here live. So we're looking at the L5 region. So what I've done here today is I brought us in a TLSO brace, and as some of our patients like to call it, a clamshell or turtle shell TLSO. And so we treat this when we need to have maximum support in the thoracic and lumbar spine. This brace will pretty much lock up all three planes of motion. And as you can see here, we have a superstructure, this aluminum superstructure here. This will actually go up into the chest area. And we're going to go, our goal when we're bracing patients with a TLSO, for the common person out there, for folks who've worn these, is we want to find the fracture site. And our goal is to get 3 vertebral bodies above and 3 below, if at all possible, and to provide a counter pressure against that fracture site. So when we're putting patients, if you're out there today and you're wondering, why did I have to have this type of TLSO brace? Why couldn't I have a softer one, or like my neighbor had, or like another patient had? Well, they're not all cookie cutter. These pathologies and etiologies require different type of bracing, and some have to be casted, some are custom molded, some are typical with off-the-shelf bracing we use. But once we pull out the custom TLSO brace, this is for maximal support. So this is a gentleman or a female who's got a very unstable vertebral body fracture, and there's a chance of retropulsion, or even they have some retropulsion, and we need to minimally have as minimal movement as possible for that patient. That's why we would use this type of TLSO.
What is retropulsion?
So retropulsion explained is, think about that brick that we described earlier with the columns and the wet cement. So when that brick actually is crushed and has a lot of compound effect on it, and it's got to disperse those bony fragments somewhere, right? Well, when those bony fragments travel posterior into the spinal column, it impedes on the spinal cord, right? Spinal cords, when you've got involvement in the spinal column, and again, that's the neurosurgical aspect, but the retropulsion is the bony fragments that travel back in that area, and you're at risk for having numbness, spinal cord injury, tingling, incomplete spinal cord injuries. That's where retropulsion, you hear that term.
Okay.
And this is just this is really just a quick overview. It's a lot more complex than that. Obviously, when you're in the ER or you're in the hospital, but this is just a good synopsis of what's going on with those different types of pathologies. So back to our TLSO here and the superstructure we're using. You can see this guy here. One of our clinicians pulled this out for us. This actually gives me the ability to adjust for kyphosis. All right. So anyone who has just a flat chest, this allows me to go back and capture that. As you can see, this is movable here. And once I tighten this down on the spinal column, it allows it to lock in. We can also move this more proximal and distal on the patient to allow us to have more control of the spine. And then, obviously, if you see these guys, these are shoulder straps. This would be used on someone who has probably an upper thoracic fracture, T9, T10 fracture, unstable, because again, to get above that fracture, remember T9 is usually at your xiphoid, which is where your ribs start, and kind of run around the side, all the way up into your sternal notch, which is about T3, T4 area. You can find your sternal notch. That's typically where these pads will sit. And so we got to get above those fractures and below those fractures, right? If we're terminating the brace at the side of the fracture, well, then it's really null and void, because then you can move and you can manipulate where you're moving. It's not bracing that fracture. So that's why the use of a TLSO brace is so important. Most men really enjoy wearing these because it helps to hold our bellies up. And most women do not like wearing these because it wants to hold our bellies up, and there's no need for it. But it is very binding, it's constrictive, but the outcome of it is very important. And so, as I tell folks, you wear this, be compliant with it for 4 to 6 to 8 weeks. You come out of it, you're going to live a happy life, hopefully, and we can get you in a good position anatomically. But if you're non-compliant, that's where it leads into other issues with the spine.
Now, do people have to wear those to bed? Like, do they wear them all the time, all day long, except for a shower or something like that?
So, very good question. Most of the time, when we see folks acutely right after their surgery, they're going to be in the TLSO at all times, except when lying supine in bed, directly flat, 0 degrees in bed. Once we start to get to 15 to 30 degrees of flexion of our waist in bed, gravity starts to work on that injury and starts to compress the spine, right? So that's where the TLSO brace comes in. So it's not black and white. You don't always have to sleep in it. It's really the neurosurgeon's call or the physician's call who's ordering the TLSO. But what we recommend is that if you're above 35 degrees in bed, you should have the TLSO brace on because it helps to stabilize the spine. And another analogy I use for our patients is we've got a water balloon. Think of the human body. We've got fluids, and if we can squeeze that water balloon, it elongates. Same philosophy with the human body. When we put the TLSO on, if we can squeeze the human body, it extrapolates and gets those vertebral bodies to relax. So there's not so much tension and force on them, so it can heal at its own pace. And so muscle spasms are decreased as a result of having a TLSO on because our body is trying to protect itself. And muscle spasms can be just as painful because you're trying to protect yourself from that injury and where it's at as the actual fracture is. So there's a number of different reasons we have patients stay in the TLSOs. And nocturnal use is not a bad thing, but certainly you don't want to be in this 24 hours a day. That would not be fun for anyone.
Yeah. Interesting. All right.
So our next column that we're going to talk about, I think, is, again, the lumbar spine. I'd like to take a second here, Russ, because the lumbar spine, as you can see, this gives a great view of that actual vertebral body and your disc. And the disc is where the cement is, right? The wet cement that kind of just hangs out. That's our shock absorbers. And this actually shows a really good view of what a decreased vertebral body looks like, or a dehydrated vertebral body, right? It just loses its elasticity. The bone actually just kind of shrinks down. And you can see here what that looks like and what a herniated disc looks like. That disc is a great picture of that. And I want to make it clear that when you have a herniated disc, it's not cookie cutter. It doesn't happen this way every time, all the time. As your neurosurgeons and your spinal physicians will tell you, these things are so complex of why they're starting and why it's beginning and what the best outcome is. And that's why your neurosurgeon or your spinal physician, orthopedist, have to make wise decisions about how to treat this. And that's why they have so much training, is to make wise decisions about how to treat these. But this picture here gives a very good synopsis and overlay of what happens in a degenerated spine, a herniated disc, what a normal disc looks like, your actual nerve roots, and how they exit the spinal column. This actually goes in depth to show as well where the nerve root exits the spinal column and why you can see how intimate that spot is in there where that actually comes out of the spinal column. So that's why it's so important to take care of our bodies with exercise and proper hydration, because most of these things can be prevented with that.
Wow.
So again, finally here with lumbar fractures, and there's several fractures that we haven't talked about today, but these are the most common that we see with lumbar spine fractures. So with compression, and you have a vertebral body fracture, you have a pedicle fracture, and what's really fun in the medical field, I think it's hilarious, is how we name these fractures, right? It's usually named after a physician who first diagnosed this fracture, or one particular fracture you can have in the spinal column is a Scotty dog fracture, and it's where the pedicles actually show up on an x-ray and they kind of favor a Scotty dog from a side view, believe it or not. And if you could ever see one of those, you would actually state, looks just like a Scotty dog, and that's why we call it a Scotty dog fracture, but it's a pedicle fracture. And as a result, those typically require surgery and are not uncommon to have, but it's a painful fracture, and it's treatable by your neurosurgeon and how they would brace that sometimes as well. So lumbar pathologies we just talked about here. Next slide is lumbar LSO braces, and I just popped up a picture of this because it's pretty common and related to the other spinal TLSOs that we've talked about today with TLSOs. Just think about the LSO dropping down one column. So Russ mentioned earlier, what does TLSO mean? And TLSO stands for thoracolumbar sacral orthosis. So we just covered 3 of the vertebral columns. Sometimes we have what's called a CTLSO, where we actually go cervical, thoracic, lumbar, sacral orthosis. And so that's a big, long term, big, long acronym. I sum it up to you like this. Your physician orders a TLSO. He is just put an order in for you to have a car. We as clinicians, as orthotists, will then evaluate you, treat you, make a recommendation for what type of car, right? It's his call that this patient needs this device, and then it's up to us and his trust or her trust in us as a clinician to make the call of what type of car you should be getting to drive. So what type of TLSO you should be getting to drive. We need to know, do we need maximum support? Do we need maximum control? Do we want to prevent flexion, extension, and rotation in the spine? If so, we have to make that recommendation. For example, a TLSO clamshell brace versus a TLSO soft, comfortable back brace that your grandmother may be wearing as a result of just having some bony fractures that are due to osteoporosis. So the gamut is really wide. That to cover that delta is hard to cover in 1 hour here of our conversation. There's so many different types of TLSO braces out there. But again, that's a very good analogy. You're getting a car. We just have to determine what type is going to be best for you. So this is, again, different type of LSO brace, just a dumbed down TLSO. Spondylolisthesis is a pretty common issue we have. And then this slide here that you're seeing on your screen is what's called an LSO with a hip spica. And you think, well, what's the purpose of this? Because my leg's not involved. We will sometimes use these on very low L5, S1 fractures because L5 and S1 is where we start to get hip involvement in flexion. And so if you're walking down the hallway or running outside, your L5, S1 junction is where a lot of that movement is taking place as your hips are swinging back and forth. And so if I can limit how much movement you have down in the sacral area and the L5 area right in there, then if I limit how much flexion you have, then I can keep that fracture site more stable with the brace. And so anytime you see someone wearing a back brace with a hip spica or a thigh cuff and an actual metal joint hooked on the side, that's the purpose of that. It's a hip spica to prevent any movement happening in that lower spine. Pretty complex injury you have to get one of those, and pretty involved actually, and very difficult actually to injure that area.
Well, it looks like it's very difficult to brace as well. That looks complex.
It is. It makes for a long day.
Lots of measurements.
But typically outcomes are good.
All right.
Boom. So that hopefully that gives our audience a very good synopsis of bracing and how we treat patients here at POI, and our protocols we use for everything from cervical through sacral spine. These are a lot of fun, and I hope they're educational for folks to use with, if you're not wearing one and you haven't worn one, you probably have a relative that's worn one. And they are needed, they are a necessity, and they certainly help to provide positive outcomes for our patients.
Well, thanks for sharing. I sure learned a lot from this conversation now. You know, as we talk about these in our staff meetings and everything else, I know more about what a TLSO is and what it's supposed to, what condition that it covers and everything. So I think it was super helpful, super informative for me. So thank you for your time.
You got it, guys. Thanks for joining us.
All right. Again, my name is Russ Sorrells, and I'm with the Prosthetic and Orthotic Institute. This is Kelvin Jones. He is lead clinician at the Prosthetic and Orthotic Institute. We are located in Pineville, North Carolina, Rock Hill, South Carolina, as well as Lancaster, South Carolina. So not Lancaster, it's Lancaster, South Carolina. I lived there for a while, so I learned that. They correct you on that very quickly. So, all right, my man. Appreciate you.
All right, guys, have a good day.
See ya.